Welcome to New Thinking for a New World, a Tällberg Foundation podcast. I am Alan Stoga, your host. Each week, I bring you conversations with people who think differently about the great issues that are shaping our world. Geopolitics, disruptive tech, mass migration, the changing climate, culture wars, all of it is grist for our mill. I hope you enjoy listening. I also hope you will let me know what you think and that you join the conversation at Tällbergfoundation.org. And now for today's episode of New Thinking for a New World. Let's start with the good news, which is not necessarily a habit for this podcast. It is this: the world everywhere has become dramatically healthier over the past 75 years, and especially since the turn of the century, pandemic notwithstanding. Almost every way and almost every place. Since 1960, life expectancy globally has increased from 53 years to 72. Diseases like smallpox and polio have mostly been eradicated. Maternal and infant deaths declined extraordinarily since 2000. The speed at which new vaccines, therapies, and protocols are developed and deployed is extraordinary. Witness the response to the global pandemic. Of course, there are still problems and new challenges emerge constantly, but in global health terms, this is as good as it's ever been. But not good enough. Healthcare is intensely personal. Don't tell me about global statistics. Tell me why my baby in rural Uganda is having trouble breathing, or why my aging father in New York went into the hospital with a broken hip and may now die from MERS, or why my wife in Buenos Aries can't get ordinary cancer drugs. We always we need better outcomes. So does Dr. Kristian Olson. He's an American internist and pediatrician on the one hand. On the other hand, he is a designer who helped create the Center for Affordable Medical Technology, which for the rest of this conversation, we're going to call CAMTech, that works to use technology to produce better, affordable health outcomes, especially for the great majority of people who don't live in the U.S. or Europe. Welcome, Dr. Olson.
Thank you, Alan, for having me. I'm really excited to have this conversation.
So let's start. Kris, when I think of technology and medicine, I immediately imagine incredibly expensive labors probing delicate parts of brains, or 3D construction of new organs, or AI-designed drugs. But I'm guessing that's not what you and your colleagues at CAMTech think about, is it?
I think you're exactly right, that we think of those innovations which are so essential to changing the landscape to be important, but what is absolutely essential is the innovations that help with accessing the care that we know how to provide already. And so a lot of the innovations we're talking about are elegant innovations that are achievable at low cost and in a more practical manner.
So it's not necessarily about money, quite the opposite. And it's not necessarily about brand new solutions, products, proposals, procedures. I think it sounds like it's about what doctors ought to be worrying about, the patient.
Exactly. And I think that it's one of the things that really grounds us from two standpoints. You know, we live in a world right now where in the US, almost 1 in 2 doctors are what we call burned out by official scales. And I think that one of the aspects is re-engaging physicians, advanced practice providers, nurses, midwives in the joy and calling of medicine while they're solving some of healthcare's most daunting challenges, which I think are achieving access to the solutions that we already know work.
Oh, I need to pull on that string. 2 strings there. One is burned out doctors, which sounds like a scary phenomenon. Is that global, do you think?
I think it's largely global, but we have some of the best data from developed countries. And it peaked in the United States at 53% during the pandemic. And they're really lauding how it's improving. It's decreased to 45% right now, which means almost 1 in 2 physicians is on the verge of burnout. And I think some of the questions that people ask is, well, maybe there's something particular about physicians. Maybe they have lower resiliency, have higher expectations. And when you go back and look, there's been some great studies done. What do these people look like before they go to medical school? And they actually have higher levels of resilience and mental health. It's the systems and the processes and likely the nature of the work that is causing these unprecedented levels of burnout.
Obvious question. Does burnout translate into lower quality healthcare, worse outcomes?
Absolutely. So people that burned out and have less feelings of self-accomplishment, feelings that they can change the world around them, have more emotional detachment, just perform worse as physicians. There's much more errors. There are many more errors that are caused by physicians that are burned out. We live in a litigious society. There's more legal cases brought against those physicians, but the biggest thing is there's just worse outcomes for patients, for physicians that are burned out.
So that's the other thread to pull on, which of course is outcomes, because the goal of the exercise is more health, not less health. How do you think about innovation? You touched on it already. How do you think about innovation using existing processes, therapies, protocols, whatever those technical words are, more efficiently, better, more targeted?
Yeah, and I'll really divide this into and then recombine them. But at the Consortium for Affordable Medical Technology, we started by this simple question. I'll tell you something that really changed my worldview is early in my career, after a year of spent on the Thai-Burmese border with Burmese refugees, I was back in Boston and invited to lead an initiative funded by the Department of Defense between MIT as a solution-rich environment with MGH, a problem-rich environment. And they asked me in particular, how do we solve problems?
Define MGH.
Yes. The Massachusetts General Hospital located here in Boston.
Thank you.
And so this charge came and I was skeptical at first, saying, look, I think our biggest issue is developing human resources. But I saw actually where if you have the right tools and processes in place, people actually perform their work better. And when we started having meetings, I was really confused. Why were we sitting in Kendall Square in Cambridge, Massachusetts, right beside MIT, and having really brilliant people with well-meaning intentions try to solve problems for people who are halfway around the world when we didn't even really understand what their problems were? And so the way we started, before I even had the language around human-centered design, was just asking people and saying, what would you really like to solve? And what really struck me was people weren't used to being asked, and particularly being asked by people who were perceived to have high resources that had their own agendas, even if they're there for well-meaning purposes. And people are gracious, and they would say, oh, yeah. But when you really ask them, I'd see eyebrows raise and go, oh, you really asked? Yes. This approach will never work here, and here's why. And so one of our basic tenets, and now we couch all of our innovation around a process of human-centered design in healthcare. And I like to say practical human-centered design in healthcare. And the reason being, if you look at every other industry outside of healthcare that has imbibed design thinking, they get a 300% return on their investment that they put into this, and they're 75% more efficient. I can't imagine an industry that needs this more than healthcare. And really what human-centered design means in healthcare is it's a process with an end goal of implementation and a mindset. So it's two things. So the process is solving challenges using creative problem-solving techniques. to come up with answers that are more compelling and readily adoptable for the end user. And it's a mindset in which the best designers are people that have the humility to recognize their first concept of a challenge or a potential solution is probably misguided and frequently wrong. And then the empathy to realize that they need to look at these challenges from many vantage points, from all the stakeholders. And when you bring those people to the table, you come up with better solutions. And we saw that over and over again.
The obvious question, again, is an example. I've read about Prisms. Is that something you can tell us about?
Yeah. So here's Prisms is a fantastic now company that arose out of CAMTech Uganda, which has really become a nidus of innovation in East Africa. And really because it imbibed this sense of let's hear about challenges, let's focus. Einstein said if he had an hour to solve a problem, he'd spend 55 minutes really thinking about that problem and 5 minutes thinking about the solution. And they've really imbibed that. And this is in a place where resources are more limited. Time, if we recognize we have very little time in healthcare here in the United States, imagine when the ratio of patients and communities to providers is even much higher. And so with Prisms, what they recognized is that the care of newborns who are vulnerable particularly in those first 28 days of life, is they were having unprecedented rates of babies dying that were referred in from smaller outlying villages. And what they did is really start honing down on the question of why are they being referred? What are these village health workers actually experiencing when they first see a patient? And you can imagine it's fear. This baby's not doing well. They have a fever. They have pneumonia. They're not feeding well. They're dehydrated. And they frequently would say, well, boy, we need to refer those patients in. And so it takes time to refer someone to a central health facility. And during that time, without care initiated, many of those patients come into those facilities either already having passed or on death's door, and the outcomes were really horrible. What Prisms did is look and say, well, what is that? Like, we talk a lot about breaking the capital H healthcare down, that oak tree that you can't move, into its component toothpicks to deal with things you can really have agency in changing. And Prisms is a fantastic example where they said, oh, it's these frontline people that are really seeing these babies, but they need some support. They don't have necessarily the confidence to both recognize exactly what's going on and initiate therapy. And so what they did is recognize a number of the communication challenges and develop a system using SMS messages that were providing that frontline provider, usually a health extension worker or medical officer, to put in what is that baby traits right now? What are some considerations we can do? And what are some treatments we can initiate right now? And when they studied this, the referrals went down and the survival of these babies skyrocketed. And what happened is they brought down Dr. Dada Santorino, the head of CAMTech Uganda, fantastic and brilliant pediatrician. And he collected a cadre of leading pediatricians in Uganda, who themselves, when they went around the corner saying, well, what should these algorithms be? What should we be telling people? And when they really got to that level of humility where some of them would even say, you know what? I wouldn't have thought of that. And I wouldn't have thought of that. But when it's presented to me in a way, this offering of some additional thoughts right at the elbow will make me a better clinician. And so that's from the central people in the capital, and it's helping these mostly women, but men and women who are treating these newborns in villages. And I can't say enough how that principle right there is something that I think we can imbibe here in the United States?
And that's exactly the question I was about to ask you, because I can imagine some of our listeners saying, well, it's Uganda. Of course, there's problems and it's the solution works for Uganda, but not for us in the developed world. And if I look at the statistics, particularly in the United States for maternal and child health, they're embarrassing. Is this sort of process, is this sort of innovation, better word, applicable here, applicable in the West?
Absolutely. And it was just pre-pandemic where the results of CAMTech were, I was presenting on it in our own health system, in General Brigham's health system. And it was sort of at a time when people would say, oh, that's really nice what you're doing overseas for poor people. And I was like, actually, that's not what's happening. We're learning much more than we're offering. We're providing platforms to hear these end users and then putting them in touch across disciplinary lines, like not a psychiatrist with an internist, but I'm talking about a nurse or a physician together with a designer, an engineer, and frequently a business person. And so when I presented these results, I was like, look, in our first 5 years of working in India and Uganda and other places in the world, 36 companies came out of this. 23 of those companies earning revenue at the 5-year mark. But we weren't intent on necessarily just producing widgets or companies. And so when you look even beyond, 100 of these projects were not technologically related, were care process redesign, and 100 of them had gone through IRB approval and were being trialed on patients and providers. I think one of the things that really got them is one of these creative problem-solving meetings that we would have generated a unicorn here in the United States. And that was a company called PillPack that Sam sold to Amazon for $1 billion. Again, it wasn't our goal, but I think it captured the imagination of our own health system saying, can you do this for our frontline providers here? And I just added in, I said, what we're doing it for is really our frontline, is for our patients and our staff and our providers who are all beleaguered and burning out. And then COVID hit. And so we really enacted some of the principles that we'd had in overseas here in the United States. And we saw amazing results, and really along the lines of, as I said, more efficiency and a 300% return on investment, which is are really 300%, returns on better health, better outcomes, better, more efficiencies that we really haven't focused on. It's been a ceilingless limit in many domains within healthcare in the U.S. where we don't think about cost as a limit.
Do you know leaders who, regardless of where they live or what they do, are changing the world? Leaders who are not content with what is and are working hard for what could be. Leaders with both a demonstrated track record and the potential for continued impact. Leaders whose work is innovative, courageous, rooted in universal values, and global in approach or implication. If so, please nominate them for the Tällberg-SNF-Eliasson Global Leadership Prize at tällbergprize.org. The nominations will be open from March 15th to May 15th. Thank you. I read about your mobility speedometer, which strikes me as exactly the sort of example, fairly low tech, huge return in terms of the variable that I think you most care about, which is patient health.
Yeah. So thank you for asking it, because we created the Mass General Brigham Springboard Studio, which is really, it isn't something where we were exporting good ideas to develop CAMTech. We were importing good ideas from the developing world to say, how might we address problems and live into the future of healthcare that we want to see? And so the MGB Springboard Studio, I'm appreciative to the system for saying, yeah, let's give this a try. And I'll tell you, we had the tenets of design thinking, as I mentioned already, the mindset and the process of creative problem solving. And we think of every problem that we address from the angle of the intersection of the Venn diagram of desirability, so what we'd like to have happen, feasibility, what's possible in the world, and then viability, what's viable. And so when you look at that intersection, you often come up with more elegant solutions that don't rely on increasing cost. In much of the other sectors external to healthcare, technology actually decreases costs rather than increasing. And it's been the opposite in healthcare. So I'll tell you about the speedometer. Our population health management team were really focused on how do we improve care of inpatients. Let's get them out of the hospital sooner. And there is a motivation around these value-based care contracts. So giving better care at lower cost. And that really fits well with a design thinking approach. What we did is go to physical therapists, physician's assistants, patient care associates, and nurses, and say, why do you think your patients aren't moving much in the hospital? Like, what is it? And really, we had have a crisis where patients admitted to the hospital, they're feeling sick. There's a number of things in place that just prevent them from moving. And we have great evidence that when people move in the hospital, they recover quicker, they have less rates of delirium, and their outcomes are better. And so we honed down on why they're doing this. We did a bunch of interviews and observations with patients in 3 wards. And then we go through this process, and it's something that hasn't been championed within healthcare for many understandable reasons, is creativity. And many creative people are in healthcare, but because of time constraints, because of the hierarchical structure, because we're learning a massive knowledge to practice evidence-based medicine, creativity is put out the window. And so we do a number of things to get people's creative juices flowing. And it's amazing how people will really take to it. It's a muscle that hasn't been used for several years for many people within healthcare. And so with the mobility speedometer, long story short, there were so many ideas. We call it a diamond or double diamond or multiple diamonds because we diverge, get lots of ideas, and then we have to practically move forward. We converge and choose what is our hunch about the best idea to move forward with. Well, some of those ideas were really high tech and using mobility cameras or speedometers or pedometers, and we came up with a notion that, well, maybe we can take this known measure of people's mobility that is very objective, called the Hopkins Highest Level Mobility, or HLM score. It was 8 points, and one thing we said is, well, nobody remembers 8 things. That's why there's 7 digits in a phone number. Why don't we break that down, make it into 4 colors, and figure out a way to present this that will align patients, their families, the providers, all to understand what somebody's mobility is now, what can they do today. So we came up with what's called the mobility speedometer, and it's a red, orange, yellow, green that shows people that even if you're bedbound, what exercises can you do in bed, and can you improve? And if you're able to transfer, what activities can you do with transferring, and how much should you do a day? And then we translated it into several languages. We gave handouts at a 6th grade reading level that would stay at the bedside. And then the family, when they would come in, they'd encourage their family member to be moving and meeting those goals, because there's a lot of downtime in the hospital. And what we found by observation was that both the patient would remind the nurse and patient care associates that they needed to move, and the nurse, by looking at it, would remind the patient. And then I'd say one of the people that were brought into this whole conversation that were likely the least performing were physicians that weren't thinking about mobility. And I'll just to highlight, I've practiced for 26 years and I've had those cases where I'm like, I think you're ready to go. We've got this under control and this, and the nurse will follow me into the hallway and say, they haven't walked for 3 days. And then it starts this whole process of getting somebody to a skilled nursing facility rather than home. And so this sounds great, right? So it sounds great, but what we don't want is hype. Like, oh, there's this new innovation, we're going to use this speedometer. So we really measure what we do. And in this measurement, it was 72 beds, surgical and medical patients. And we evaluated them for 3 months before we ever implemented the speedometer. And then all we did is implement the speedometer and the handouts and create a documentation method through our electronic medical records. And what happened? It was amazing. Patients moved 300% more, which is great. But then you might say, well, actually, are they just documenting that patients are moving rather than actually moving because we created a system? They actually showed that patients objectively, their mobility status, instead of declining at 41% for inpatients, they only declined at 19%. And patients got out of the hospital sooner. So just in these 2,500 patients, there was 1,300 in this group where we implemented the speedometer. In 3 months, 72 beds, it was the equivalent of saving 259 hospital days at a time when, so they're better, they're getting out of the hospital sooner, which is fantastic. And it enthused the providers, the nurses, the PCAs, and everyone that they were doing better for their patients. But it also allows you this whole capacity to let 259 more patients into the hospital.
The short answer is low-tech brilliance.
I like to say it as I agree with what you're describing, but also as elegant solution that is compelling to the end user. So something that's practical for them to engage in.
Exactly. That's what I meant. It is not, it goes back to the concept of innovation does not equal high tech, does not equal the sexiest thing that just came out of somebody's laboratory at MIT. It's rather, and that, what it sounds like you're doing is transforming the process instead of aiming at the shiny new bauble. And if I can create a shinier, newer bauble, that's innovation and it's good by definition. You've reversed the lens and you're looking at the patient and saying, how do I get the patient healthier, faster? Which seems to make a lot of sense. I don't want to make this about the U.S. healthcare system since much of our audience is global, but I have to ask. The U.S. spends the most per capita, the most in absolute terms, but the most per capita on healthcare in the world. Yet we have declining life expectancy, awful maternal mortality outcomes, middle of the pack at best health statistics. Is there a short version to what's wrong with this picture? Even worse, we export a lot of that. We try to export that mindset that drives our medicine because at great institutions like Harvard, like Yale, like Chicago, we're training the world's doctors. And I'm terrified that we're training them on all the wrong things. Now, that may be an exaggeration, but it is a concern.
I think you're exactly right. We spend in absolute terms way more than other countries, but also in percentage. I think the positives are there's amazing innovation within the structures that have developed within the United States. There's cutting edge innovation that is leading to biologics and small molecules and really advanced imaging techniques that are really impacting people globally, and new ways of producing vaccines as we saw through COVID, and really in a rapid manner. And so some of our expenses are based on that. But I think that we have this misperception that we're not playing a good ground game. We're not delivering care. We're 10th out of developing nations in terms of access to care. Developed nations, yes. In terms of access to care, and 10th out of developed nations in 2024 in health outcomes. And so when I think about innovation, I think we have to really be directing towards people that are thinking, how do we deliver what we know how to do more effectively to the people that need it? And recognize that that's a value to our entire society. And there's so much that I was mentioning, and just even from your example of Prisms and other companies that we've seen overseas, other companies or interventions that are effectively delivering care to larger numbers of people without this barrier. And I will say that from CAMTech, some high-tech things came out. There was artificial intelligence before it was necessarily used through a company named Indra in India. There were other really sophisticated respiratory companies like Koyo Labs in Bangalore, and they were doing really high-end stuff. And you can say that's great. We're not stifling those sort of innovations. But where I think that we had much more of an impact are a lot of the ground game. How do we deliver care more effectively and recognize the ingenuity and insights of people that are doing this day in and day out on the front lines?
The cynic in me wants to draw the conclusion that one of the contributions the United States is making to global healthcare is we've proven that money is not the answer. Nice to have, but not the answer. It may well be that incentives are what matter much more than the sheer volume of money you throw at a problem.
Absolutely. And actually, I think money, you need a certain amount, right? You need things to move forward. But money can actually stifle innovation. And that's one of the big lessons that we've learned, is that need is the mother of innovation or invention. And when people are really sit there with that constraint, they're forced to think in a more elegant fashion and really hone in on what's the problem they're solving. And is the problem I'm solving or attempting to solve going to actually impact the people I want it to impact? And without that mindset, I think we're misguided in much of what we're doing in the United States. And it makes for a number of interventions that make good publications, which is an incentive for academic clinicians. But they're not the things that are actually necessarily always delivering the best care to our patients, that's the business of healthcare, is how do we leave the world a little bit better than we met it. And we're not here to prove how right we are or how smart we are. And so I think that this notion of really recognizing the ingenuity and the insights of people that really deal on the front lines is the magic sauce between both CAMTech and the MGB Springboard Studio.
Kris, I'm going to leave it there because I can't imagine the question I'd ask that you could answer better than that. So thank you for this conversation.
Thank you very much for having me and talking about this.
Thank you for listening to this episode of New Thinking for a New World. I'm Alan Stoga, podcast host, and I look forward to your joining our next conversation. Remember, tell us what you think at Tällbergfoundation.org.